We now move on to our final presentation for today. And I'd like to introduce our next speaker, Marie Sanderson, who's from the London School of Hygiene and Tropical Medicine, and is a member of the Commissioning Policy Research Unit. And she's going to speak about aspects of integrated care systems. So Marie, over to you, please.
Thank you very much, Raphael. I'm just going to see if I can manage to share my screen with you all. Is that looking as it should?
It is. It's not in presenter mode yet, but it's
there
good.
You go. Is that better?
Now it is. Yes, that's good. Thank you.
Thank you very much. So yes, today I'm going to be talking about our work in PRUcomm concerning the development of integrated care systems, and specifically talk about the governance arrangements in integrated care systems and how they're developing to facilitate joint working across health and social care. This is our disclaimer for, obviously, these are our views, not the views of NIHR or the Department of Health. So in terms of our research, what I'm going to be talking about today is based on a number of activities we've undertaken in PRUcomm. So firstly, we've completed research about the development of ICSs. We've conducted a qualitative case study research that's been published. Actually, the final report's available on the PRUcomm website, and there's a recent article that we published in the BMJ Open as well, detailing our findings. So I'm going to talk about some of the findings from that research, but we're also in the midst of conducting ongoing research at the moment, looking at the development of ICSs in the light of the Health and Care Act. And as part of these activities, we're in the field at the moment, but we've also analysed the Act, and we've undertaken an analysis of the 42 Integrated Care Board constitutions, which has been led by my colleague, Dorota Osipovic, which I will talk about later as well. And all of our research activities are really focused around these central questions concerning the development of collaboration in integrated care systems. So issues such as how are leadership and cooperative arrangements governed? How are partners in integrated care systems balancing collective and individual interests? And how are local priorities, including those of local authorities, being reconciled with wider system priorities? And what kind of decisions systems are actually making regarding the allocation of resources? I imagine most people by now are familiar with integrated care systems. I mean, essentially, they're an NHS policy initiative, which is a development really of the ongoing movement in policy, which has the objective of improving the delivery of care through breaking down barriers between different organisations and care sectors. And the specific logic of integrated care systems within that is that of collective decision-making. So the idea is that collective decision-making across NHS with wider partners has the capacity to lead to more joined up health and care services for local populations, and also that it's going to help health and care organisations to tackle complex challenges which they wouldn't be able to deal with individually. And there's a raft of benefits which have been envisaged for integrated care systems, as detailed in the bullet points on this slide. So the expectation is that working in this way, using collective decision-making in integrated care systems, is going to lead to these very substantial improvements. And additionally, I think it's worth pointing out that some aspects of ICS working are very specific to the NHS. And this is even more so the case following the Health and Care Act. So ICSs now have responsibility, for example, for the provision, for securing the provision of health services in their local areas. And they've also got this strengthened focus on NHS budget and NHS performance. ICS is also organised according to these three tiers. So it's a spatially defined model of systems, and within systems you've got places, and then within places there's also neighbourhoods. And there's the expectation that different types of activities aimed at increasing integration, increasing collaboration, are going to take place at these different scales. So at the system scale, the idea is that it really focuses on strategic change, on the development of governance and accountability arrangements, and also on the management of performance and of collective system resources. At the place scale, the focus of collaboration is assumed to be on the planning and delivery of joined up integrated services. So the integration of hospital, council and primary care teams. And then the smallest population level, neighbourhoods, primary care networks are expected to focus on integration of primary health services with community healthcare services and other local health and care organisations. An important question that we kind of seek to address through our research is to think about what is distinct about integrated care systems, which are going to help them achieve their aim of increased integration. And what perhaps is distinct is these broad principles through which decisions are supposed to be made in ICSs. So the first of these is the consensus approach to decision making, that the aim is to reach agreement across all partners about the way forward, rather than, for instance, taking a vote on what should happen. And consensus is linked to the idea of organisational sovereignty. So ICSs don't have any hierarchical controls, they're network arrangements, and they rely on reaching agreement between individual organisations who each have their own individual roles, accountabilities, and statutory responsibilities. So in ICSs, partners are asked to put aside their self-interest, their best for organisation hat, if you like, and make decisions on what is best for system, the best for system principle. But necessarily, it's the case that decisions made in ICSs are non-binding and voluntary due to organisational sovereignty. Two more important principles of decision-making, collective decision-making in ICSs is firstly subsidiarity, so that decisions should be taken closest to those they affect. And secondly, the local agreement of the rules of the game. And this is an important concept that ICSs operate within a very kind of permissive national context, and they can decide locally how the governance arrangement should be structured. So, for instance, it's up to ICS partners to agree between themselves what constitutes a place and what decisions should be made in that place. Arguably, there's little that's structurally that's changed since before ICSs. So ICS working is essentially, it's relational in nature. It depends on soft power and relationships rather than structural changes. And it's worth emphasising, particularly in light of the expectations that have been put on ICSs, that there haven't really been any substantial changes in the formal structural mechanisms through which integration between health and social care might be achieved. So, for instance, ICSs are making use of pre-existing mechanisms which allow the pooling of budgets across health and social care, for example, Section 75 arrangements and better care funds. The recent Health and Care Act has put in place a kind of strengthened architecture to try and ease collaboration. And there's these various things it's put in place. So it's saying that there should be greater clarity regarding duty to collaborate across the NHS and local government and what that might mean in practice. There's this triple aim duty for NHS organisations, which means they've got to act with regard to general health and well-being. And there's also new flexibilities around the joint exercise of functions with local authorities. And the final thing is obviously the creation of these statutory integrated care boards and integrated care partnerships. But the extent to which the meaning of the impact of these this increased architecture hasn't been seen yet, because it's we need to be in the field to see how local systems are in fact making use of some of this strengthened architecture. So, for example, how are they interpreting these new flexibilities around the joint exercise of functions? So it's something that we're looking at in our current research, is what exactly these kind of this strengthened architecture, and what meaning it has locally in systems and what impact it's having. An important factor in terms of collaboration across health and social care through ICSs is the issue of representation. So who's got a seat at the table? In the period before the Act, there were minimal requirements actually regarding who should be involved in integrated care systems. So guidance suggested that the partnership board should be drawn from commissioners, from local providers, from local authority, and from the voluntary and community sector and other partners. And in practice, in our case studies, what we found was representation of the social care sector tended to be through local authority representatives on partnership boards and place-based partnerships, commonly directors of social care, directors of adult social care, or directors of commissioning, and that there was a much more limited representation of other wider partners, including providers of social care. Under the Act, in some sense, the requirements for representation is much more prescriptive, particularly in relation to how local authorities should be included on statutory ICBs and ICPs. But it's also the case there's still much left for local discretion, including how wider partners should be included in the work of the ICS. The requirements for representation on statutory ICSs suggest that although local authority involvement is now formally required, it's still a matter of local discretion, and consequently, so what these bodies look like and who is around the table is going to be subject to a great deal of local variation. So ICBs, the Integrated Care Board, are statutory bodies responsible for the planning and funding of most NHS services in the system area. And these bodies now have formal constitutions, and there are requirements regarding who should be on the board, with some flexibility for local additions. So in terms of local authorities, the Act stipulates there should be a minimum of one partner member from the local authorities in each system on the board. So there should be one is the minimal stipulation. But interestingly, our analysis of the 42 ICB constitutions across England indicates that this minimal specification is being exceeded. So 28 ICBs have designated additional partner members in their constitution from local authorities, and 22, that's about half, have in fact put in place sufficient number of local authority partner board members to accommodate all of the eligible local authorities on the integrated care board. In terms of integrated care partnerships, this is a statutory committee formed between the ICB and all the upper tier local authorities that fall within the system area. And it's responsible for putting together the integrated care strategy on how to meet the health and wellbeing needs of the population. And unlike the Integrated Care Board, the ICB actually has very few formal membership requirements beyond that the ICB and the local authorities are statutory members. But there are lots of recommendations in guidance regarding the fact that this is a forum which should lead engagement with wider partners, including social care providers. And we're going to, in our current research, look at how this is working in practice, including speaking to social care providers about whether they are, in fact, being included in integrated care partnerships in our case study areas, and how that is structured. A large part of what we're interested in, of course, is how these arrangements are working in practice. And we have findings relating to that from the period before the Health and Care Act. And we're obviously currently in the field looking at the development of collaborative working in ICSs under the Act. So unfortunately, it's really too early to share any of those findings. So I'm going to talk briefly about the findings from our first research study. In terms of engagement of local authorities in the work of ICSs, the local authorities in our case studies were keen to be an equal partner in the work of the ICS, but had concerns regarding whether they were in fact involved in an equal partnership. So they wanted to drive the integration agenda together with the NHS and other key partners, but there was a fear that they would in fact be the last thing you came to in a very health-focused system. One of the factors that appeared to make a significant difference in this regard was the alignment of system footprints and place footprints with local authority footprints. So a lack of alignment, we found, made the engagement of local authorities in strategic commissioning and planning much more difficult to achieve. We found the difference in institutional context between the NHS and local authorities had the potential to present a significant challenge to joint strategic planning, which it was difficult to overcome through the mechanism of collective decision making. So contributory factors included the difference in business and planning cycles, the wider remit of local authorities, and the differing approaches to procurement. And there were also concerns from local authorities regarding the impact of system decisions on local authorities, specifically the implications of a loss of control over local authority finances. So there were concerns about the risks which they were exposed to in relation to system initiatives which were aimed at achieving financial sustainability for the NHS. So these included the risk that moving acute activity out of hospitals might increase the demand for social care services, and concerns that any savings that were realised would only be directed solely towards the NHS. I wanted to finish by sharing some of the decisions which have been made in integrated care systems in our case studies, and specifically in the place-based partnerships. So at this level, we found many examples of a shared approach that was being taken across health and care providers to workforce development, to sharing of population health data, to care design and delivery. And this slide gives some examples of those initiatives. So the feeling was that places actually with scale that were working really well for making decisions leading to more integrated delivery of services. What was much less clear in our case studies was how much progress was being made about larger scale, more strategic collaborative working, where perhaps some of the scales of the risks, the financial risks that would be incurred were getting more significant and were acting as a kind of a block to collective decision making. So in conclusion, what we can see from our earlier research is that that structural differences between health and social care can really inhibit collective decision making and collaboration, but also that the local context is really very, very significant in terms of the ease with which collaboration can be achieved, especially this alignment between footprints across health and local government. And there are a number of questions that we're seeking to answer through our ongoing research, which are really important in terms of the development of joint working. The first factor is the capacity of the Health and Care Act to kind of ease some of these structural problems and facilitate collaboration. Another key question is, in light of the strengthened focus of ICBs on NHS issues, on NHS performance, how's that going to impact on the kind of the wider partnership agenda of ICSs? And the third area is really how the ICPs and place-based arrangements are developing, where there's the expectation that much wider partners are going to be involved in the work of the ICS. So those are the kind of the factors we're really looking at going forward with our research. Thank you.
Thank you very much. That was a very interesting and informative presentation, which many thanks. And we've got a few minutes now for questions still. Can I invite questions, please? And actually, if you could stop sharing, that would be really helpful, so I can see the whole screen.
There you go.
Thank you. Great. So, any questions? Well, if not, can I start with a question? I was wondering whether you found variation between different areas, for example, between places where local government was two-tier, with housing locally and the district level, I mean, and social care at the upper tier level, or indeed between poorer and more affluent areas where more affluent, there are lots of self-funders, so the local authority's role doesn't cover nearly as much of the provision as in the poorer ones. Yeah. So I was wondering whether you explored at all these issues of differences between different types of areas.
Yes, we did for the former. We didn't so much in terms of the affluence of areas, but we definitely, in choosing our case studies, we were very interested in different models of local authorities and to get some kind of variation across our case studies on that front. So we had one system that had, they're anonymous, so I've got to be careful. We had one that had a great number of local authorities within the system, probably about 7, I would say, and we had one that had was nearly coterminous with a county council, but was a two-tier one. So you had the district and the borough councils as well. So we did want to try and capture variation on that. And it is very important because in the area that had many local authorities, we found that that the engagement was really at place scale. So they had a tremendous struggle in these areas because the footprint was so difficult to agree between local authorities and between the kind of residual health footprints. So in the end, the engagement of local authorities was very much at place scale, and they were almost like mini systems. I don't think there was much joining together at system scale. So the place was really the unit of interest in that system. Actually, we did look in the other system where we had the district and borough councils. they were round the table in the places, and loved being round the table in the places. And actually it opened up a whole new agenda about housing and those kind of discussions. So that was actually a really kind of fruitful engagement for that system, from that two-tier system.
Yeah, thank you very much. Kimberly Green, would you like to ask your question, please?
Hi, Marie. Thank you, Raphael. I think you've asked the question, Raphael, that I was going to ask, but in terms of my question, no, it's all right. But my question is more or less on, variation on affluence and things like that. But I know you've mentioned early on, Marie, that the research is still ongoing, but there are any insights you can share on whether there's variation in terms of how the ICSs have progressed in terms of forming the governance. So I know they weren't really given a formal guide on how to create these boards, but are there some areas that I think, you think are more advanced than the others? And if so, what do you think are the factors that could have influenced the facilitation of such collaboration? Thank you.
Oh, golly. Okay. I think it's very, very early days for our research. Obviously, we know that all systems have got the ICBs in place because they had to have the ICBs in place. So, but what I think is really hanging in the balance at the moment is the question of the ICPs. And I think that's really challenging for them to find a way to engage meaningfully with much wider partners than they perhaps have previously, and to find a way to make sure they're meaningfully engaged with things like social care providers who are very diverse. There's very many of them, and to try and reach out and make sure that they're kind of engaged in the ICP agenda. And I think all our systems actually know that it's not that they're on the back foot, but they know that that's something that's going to take quite a while actually to put in place. So I'm not sure I can say much more at this stage, given how early on our research is. But I think yeah, that's probably one of the biggest challenges facing them, is around kind of widening participation.
Thank you.
Yeah, thank you very much. So thank you to all, and see you next time.